Good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, would like to welcome you to the January monthly webinar. Today's topic is Behavioral Healthcare and Geriatric Dentistry, presented by Dr. Andrea Holzner. I would like to take a brief moment and thank our partners for their support so that we can bring you these monthly webinars. Our partners are Midwest Dental Equipment and Supply, Cook Children's, Methodist Healthcare Ministries, St. David's Foundation, Practice Analytics, United Healthcare Dental, and the Oral Health Progress and Equity Network. So thank you all for your continued support. And we hope our attendees enjoy these webinars. Our presenter today is Dr. Andrea R. Holzner, a gerontologist and founder of the Alzheimer's Integrative Wellness Group in Portland, Oregon. Dr. Holzner speaks and trains nationally on rural aging sustainability, Alzheimer's, and provider support for medical, audiological, and dental healthcare professionals. She has presented at various conferences on the complexities of caregiving, rural aging, and supporting providers who work with an aging population. As a neuropsychologist, gerontologist, and published researcher, she is actively involved in helping provide those with Alzheimer's and their loved ones achieve the highest quality of life. Via the troika of her degrees, gerontology PhD, post-baccalaureate in neuroresearch, master's in psychology, Dr. Holzner is able to address the full diapason of psychological, social, environmental, and medical challenges facing those in the aging ecosystem. It is my pleasure to introduce you to Dr. Andrea Holzner.
Good morning. Good morning, everyone. Thank you so much for joining us today and inviting me to talk on a subject that I'm incredibly passionate about and very excited to speak more to the oral health community. And it's the closest that I've come to Texas in about 10 years. So it's kind of exciting for me to be joined again with Texas. So I'll just begin today by saying behavioral healthcare and geriatric dentistry is growing, and it's a very critical point, especially as our aging population growth continues significantly. And to be prepared, to have the awareness, to have the comfort and structure that our oral health care providers and staff need and have implemented will just make everybody's lives much more easier as we continue. Let me see. So I'm going to try and put a lot into this brief time that we have together. I'm going to go through some brief definitions, talk about what older adult care is all about, and the geriatric patient. Look a little bit at the aging process, social, behavioral health, environmental factors that play into oral health. Looking at behavioral health care, and of course, gerontological factors and health equities, looking at different perspectives when working with geriatric patients. And then looking towards sustainability and our treatment planning and how we can continue to serve this demographic and also keep our staff and our providers informed to what's happening today. So hopefully you will come out of this a little more aware of understanding who geriatric patients are and their oral health care needs, recognizing geriatric treatment planning, and looking at the different components of modifying services, resources, and the integration of other providers and information that will help enhance your practice. And then define, again, sustainable geriatric practices so that as our population growth continues, that we are established and prepared. So a few definitions, and I think most of you probably know these definitions, but for the sake of this presentation, I'm going to be referring to Alzheimer's disease instead of dementia. Dementia, in fact, we used to refer to cognitive decline and Alzheimer's all under the umbrella of dementia. Dementia is really just a cognitive impact. So that can range and vary, but for sake of looking at the geriatric patient in terms of cognitive decline, I'll be referring to Alzheimer's. And it affects, of course, memory, thought process, behavior, and it really impacts a provider's ability to treat and provide services, and as well as the communication, which we'll get into. And you're especially working with the caregiver, which is an important component, which we'll get into. In terms of geriatric and the geriatric patient, when I was doing my research last year, I spoke to and interviewed several providers, and all of them had a definition of geriatric patient as anyone 65 and older fell under that geriatric patient umbrella. In terms of what I'm explaining, and I think as we go forward in the community, in the medical community, geriatric patient has a very unique set of conditions, whether it's cognitive, physical limitations, it could be prescriptive misuse. I put addiction loosely, but anyone that is under the umbrella of polypharmacy and the complexities of comorbid conditions. So the geriatric patient has a very unique subset of situations, whether it's mental, physical, or sort of prescriptive. And then, of course, going into geriatric or gerontology, that is oral healthcare for geriatric adults. And again, geriatric being not just the blanket of older adults, 65 and older, but having, again, the subset of conditions that also include comorbid conditions as heart disease, diabetes, if they have Parkinson's, Alzheimer's again. All of these complexities affect how we deliver services, how we implement treatment planning, communication, et cetera, as we'll go into. And then really looking at behavioral healthcare. Behavioral healthcare is, in terms of Alzheimer's disease, as Alzheimer's progresses, not only affecting the thought processes, it affects our behaviors. We have the limitations of communicating Alzheimer's patients what their needs are, even the communication that is direct of what is hurting them or what is happening in their lives. There's barriers to physical and mental, and looking at, and we will go into this, looking at the barriers between behavior and healthcare. And behavioral health, again, focuses on mind, body, and emotion, spirit, or whatever you believe. So I want to get into just a tiny bit of Alzheimer's statistics, because I really want to exemplify why this is so important to understand behavioral healthcare, oral healthcare, and geriatric dentistry. We all know that our aging population growth is significant, and it's continuing at I'm almost will say at an alarming rate, because I don't know if we're completely prepared with our systems and our providers. And currently we have roughly 54 million older adults in the United States, 65 and older. It's roughly 17%, and that upward trend is really looking at the high 20s. In Texas, and I really struggled with Texas. I looked at probably 24 sites to really get an idea of their over 65 population, but roughly 3.8 million, probably more than that, and somewhere 13+% of the Texas population. Texas was ranked 4th in the United States with Alzheimer's cases, which I thought was very significant, and 2nd in Alzheimer's deaths. About 400,000+ have Alzheimer's in the state of Texas, and in the United States total 6.2 million. So as we can see, aging in Texas today, 3.8 million. The projections based on those baby boomers, which I say that quietly because I am one, is changing the whole demographic of our aging population. So it's projected to be upwards of 4.7 million, and then by 2050, 8.3 million. So we really, having this training, having the preparedness, understanding Alzheimer's and geriatric patient needs, and being prepared with equipment, resources, comprehensive approach, it will get us there. Looking briefly just at some provider statistics, this was primarily the medical profession, but it also included some dentistry and audiology. About 50%, if not more, are not prepared for for Alzheimer's disease. And 82% or more are not confident in their care with Alzheimer's. And I'll just say geriatric patients, 39% roughly report that they never or sometimes are comfortable with the diagnosis of Alzheimer's. So when patients come to you with cognitive decline or cognitive impacts, I think less of the labeling and more of just where they are in that moment, looking at the autonomy of that patient. And I speak very passionately to providers about autonomy because it's so critical in their treatment planning and communication. And 65% reported that they had very little training. So to me, these are somewhat alarming, and it really identifies the need for us to be prepared and understand a whole demographic of patients. Just briefly, a few high-risk determinants in Texas. When we're talking also about rural aging, which is so passionate for me and what I present, many times geriatric patients have limitations with housing, with transportation to meet oral health appointments, to get the support that they need. language barriers within Texas. I looked that 17% are foreign-born persons in Texas, so definitely having someone on staff or a translator to really understand. Also for as a oral health provider, for marketing and reaching that population is so critical. Of course, I won't get into it for the sake of this, but our health system, looking at Medicare, Medicaid, the limitations around oral health care, those absolutely need to be modified. And just looking at older healthcare needs that are immobility, cognitive limitations, hearing, looking at something we like to look at in rural settings. Primarily, I look at the social environmental index, and that's even access to basic needs, healthcare, et cetera. So it's very critical to understand and be able to reach out to that population. I won't go into this that much, except to say, and I think the Texas Oral Health Coalition is so fabulous in what they do, because they're really working to make changes in these areas. But something to really focus on for older adults and geriatric patients are terms of payment, their insurance coverage, access to rural communities, their financing options, et cetera, maybe referrals to dental schools if that's an option, and to really have this preparedness. So when you're approached by an older adult or a geriatric patient, that you have something to provide to them, a resource. Again, in rural aging communities, which Texas is, of course, primarily rural health, is really having those integrative and comprehensive approaches and those resources and services available for referral. So I'm going to jump into right now what is looking at specifically the geriatric patient. So I know quite a few adults that are 65 and older, 75 and older, and we're doing a lot of research together. We're writing together. And if I ever use the term geriatric with them, I might be decked. I don't know, but it's somewhat of a derogatory term to define older adults in general, because the majority of older adults are very active in the community, and many are working, and they're enjoying their lives and managing any type of health conditions. So their health conditions are not limiting. So I want to look at non-normative aging in terms of the geriatric patient. We're looking at more cognitive, physical limitations, functional limitations. We're looking at cognitive, of course, changes, impairments. In the research that I did last year, we looked at how many older adults and geriatric patients were not able to afford oral health care. So PCPs were having to just treat their pain. So they had chronic pain, and basically, in all honesty, were being treated prescriptively just to keep their pain. So they weren't dealing with the real root, no pun intended, root cause of their pain. And of course, hearing, audiology, all of these areas that are not always covered by Medicare, and states, as Texas, that have limitations drastically with Medicaid. So, and then we're looking at frailty with the geriatric patient, if they've had falls, if they have comorbid conditions, also, again, going back to diabetes, looking at heart disease, looking at physical limitations, incontinence, and then some geriatric patients that have the whole gamut. And we'll get into that more. And again, I just want to say the majority of adults are active, healthy, and yes, they might have some health conditions, but it's manageable. And no way would I ever refer to them as geriatric. I'll just let you read this later, but this is just a little bit of dementia, really looking at the neurocognitive impacts. And what I really want to focus on for this talk is looking at more of the behavioral healthcare, because that is going to impact your services, your treatment, your communication, sustainable planning, and really working with the caregivers and loved ones of Alzheimer's patients. Alzheimer's, in terms of the whole neurocognitive decline, makes up the majority. Again, vascular dementia related to heart disease, strokes, and then there are various other types of dementia. So behavioral healthcare, again, focuses on the biological, of course, the psychological and social aspects. I would also say environmental, because it really affects the interaction, interpersonal relationships, their daily activities, toothbrushing, et cetera, just their daily ADLs, their daily practices. In terms of primary age-related physiological aging, that's just looking at, I guess, what you would call normative aging. And with that, there might be some physiological changes that we see, our body structure. Somewhat, we could have moments of lapses of memory, nothing we can't live with, some things I don't mind forgetting. And of course, there's oral health changes that we're looking at, and we'll go into in terms of maybe developed caries, not brushing their teeth frequently, or loss of teeth, looking at dentures, etc. The secondary, more pathological and disease-related, again, Alzheimer's, looking at more in terms of Parkinson's, etc. And then atypical presentations are more really severe, and those numbers are increasing. I read some research recently that talked about over 60%. When I did my research, I was so alarmed by polypharmacy that it's motivated me to begin doing more research and writing on deprescribing, looking at polymorbidity, comorbid conditions, as we talked about, and polypathophysiological conditions. And those could be PTSD when you're working with veterans, really when you're working. The thing I would like to just laterally say is with Alzheimer's, many of my patients start if they had PTSD or other mental health related conditions, those pathologies could rise because of the changes in thought processes. So it can be very complex, and I'm not asking you to know all this, except to say, when you're looking at patient autonomy, it's really important, as we'll go into, really doing the background, talking with patients, loved ones, maybe even the PCP or other providers, and really getting an assessment before you start treating. And that again comes with functional reporting, interdisciplinary teams, integrative, knowing your resources, and of course, geriatric training and understanding a bit about behavioral healthcare, keeping up to date providers and staff. I won't go into this a little bit, except to say here are some comorbid conditions that we're talking about, and they definitely impact oral health care. So as providers, when we're making decisions and we're looking at treatment planning and services that we provide, and how we even, what that practically looks like when we're going through the motions of bringing in a geriatric patient, whether they're in a wheelchair or not, and looking at, is your practice set up for this? How do you move them to the dental chair? How do you approach them communicatively? What type of verbiage changes do you need? How do you explain what's happening when they're not able to fully grasp the concept? So this, to me, looking at more of what goes into your behaviors. And again, I think we look at our attitudes towards that particular group of geriatric patients and recognizing any biases for providers or their staff, and really addressing them and being well informed and making some changes to that. Looking at our subjective norms, how do we view someone when they first come in, and does that affect our intention or our behavior? And then looking at our perceived control beliefs, and that really comes from our system, from insurance, from ADA, from other oral health providers, and what are limitations, and what are barriers to treating geriatric patients. I'll bring this up just briefly so I stay on track. A couple of themes that I found surprising when I did my research last year, really looking at the emergent themes that were so critical were the limitations of geriatric care, and especially all around Medicare, and of course Medicaid, and the limitations of all that. Really the need for comprehensive and integrative approaches, having preparedness again for resources, looking who's in your county that you could work with, that you could call if you have questions regarding comorbid conditions or other forms of treatment planning. Polypharmacy, perhaps in your community, working with a pharmacist to really understand drug interactions, and how, as you are utilizing any prescriptions, if there are any interactions, and that pharmacist can really help assuage any fears proceeding with that treatment planning. Barriers to patient care. Again, we talked about transportation, family support, limitations with that, of course, financing, payment. And then lastly, what was so incredible for me was really learning that aside from all of those barriers and limitations, all of the providers that I interviewed had a huge joy and fulfillment in treating geriatric patients. So that not only gave me goosebumps, but that gave me hope that we can get out there and really train and bring bring providers into serving the geriatric population. So healthy versus geriatric patient, a healthy adult, mental coherency, they're active, they're functioning with any health conditions, and you can provide normative dentistry in terms of services and explaining flossing, any types of treatment planning. Whether they do it or not is another question, but you're able to provide that service. With a geriatric patient, you're really also, and especially with Alzheimer's, you're working with a loved one or sometimes a care facility, which we'll go into, or a different housing community. And so you're working with their PCP potentially, or the nurse that's involved. And oftentimes what I found with nursing homes is that dental hygiene or geriatric care, geriatric oral health care only comes in emergent situations, which is very unfortunate. So you have more prescriptive challenges, of course, cognitive. With the cognitive decline, it's how to convey the needs, how to convey the types of services that might be needed. You're looking at frailty and mobility. Are your practices set up for this? Do they have the sufficient room for a wheelchair? And how do you train your staff to work with immobility or frailty, as well as cognitive challenges? The dependent adult, whether it's with PTSD or trauma, Alzheimer's, or medical conditions, I think it's important, again, with autonomy, to look at where that patient is currently, what they're experiencing, and understanding that particular behavioral health condition or medical condition and what their needs are, what their limitations are, and connecting those oral health practices with that particular condition. Awareness, supported with activities. I say awareness also in just reaching out to those communities and providing that integrative community service. Of course, safety. We're looking at physical, and I say emotional safety, but I'm talking really in terms of your verbiage and communication, which we'll get into, and empowering, healing, and not re-traumatizing, which I don't want to put that pressure on you to not re-traumatize. Verbiage, the physicality of leaning over someone that has trauma or Alzheimer's can be somewhat invasive and very scary and have the opposite effect of what you're trying to do. Choice and empowerment, of course, working with loved ones, caregivers, and just focusing on the positives and what can be done. I won't go into all of these. You can read this later, but understanding the person is a person, not just a health issue. And that's why I can't say enough. Autonomy in healthcare, is in oral healthcare, in dental, and audiological, and medical. It's so important to really understand this particular person, recognizing their environmental needs, learning communication, again, engaging in the community, being a resource, somehow providing outreach, minimizing language barriers. If you have marketing, that it's marketed in the different languages, or you have that option, and really providing resources and services that can reach like rural health communities. And of course, just finding a positivity and laughter with and joy with it all. Briefly, a few social changes that impact oral health care for geriatric patients. It's family support or limited family support and housing. Sometimes they have to move, your patients have to move into nursing homes or a more dependent care because of their cognitive decline or physical decline. The mobility to and access to care. And sometimes coming in, there's a tiny bit, especially as adults develop or first diagnosed with Alzheimer's, there's a little bit of a social stigma, a social, I would say, embarrassment that I found, and they almost minimize their care that they need because of all the changes. They don't really even know how to approach the provider. So there's that element as well. And then the sensory perception to surrounding, hearing, communication, etc. Behavioral changes, again, of course, with cognitive decline, they could be forgetting denture care, toothbrushing, and of course, I don't need to say what all develops: oral diseases, infections, their general health. There's so many researchers out there that have shown of course, the connection between oral health, gum disease, infections, correlated with a form of dementia. And so there's a real opportunity for oral health providers to not only enhance their training and their practices, but also laterally to conduct more research that really assuages a lot of fears for geriatric patients and families. And so you're looking at these psychological impacts and how do you motivate them to maintain this health, or their loved ones that are maintaining their health. So the nitty-gritty of your role as a healthcare provider. Definitely, I would say continue to take didactic courses, trainings, etc., that focus on specific areas. Really looking at courses as well that go into role playing or examples, bringing up your specific needs, maybe even working with someone in your community. Again, that integrative, collaborative support for resources, identifying new aspects of preventative measures, preparedness, looking at alternative services and how that looks, maybe even different types of equipment that might be implemented. And some of course, the pharmaceutical aspects that play into any surgeries or health treatment planning, and really, again, know your patient. I won't go into this again. It's just looking, again, really focusing on that geriatric care, working with their loved ones, social workers, in the environmental factors, especially in rural communities where they might not have the support that they need. One of the elements briefly laterally is that in my research, I noted that several providers, and perhaps you find this in your own practices, many times your role as a provider is beyond the scope of what you're doing. You're helping to look for services, you're helping to even look for financing, etc. So I think providers, whether it's medical, dental, audiological, are completely heroes in my eyes. So one of the components of working with geriatric patients is focusing on communication. And I found this more for the caregiver working with a geriatric patient, but I also think it really helps to be aware and identify how important your verbiage is for someone that has Alzheimer's. And never arguing, agreeing, because what I want to say is they don't always understand, and they're not able to understand the complexities. So it's very important to understand singular concepts. Someone with Alzheimer's, depending on mild, moderate, or severe, you couldn't say, later today, we're going to the store or we're going to the dentist to have an exam. All those are several concepts. With Alzheimer's, it's very singular and it's really in the moment. So you have to look at very singular ideas, singular concepts, and just agreeing, because they're not really purposefully arguing or trying to be disagreeable. It's very difficult to reason. I really teach diversion and really redirection. Redirection to me is like the ultimate with someone that has Alzheimer's. And if you're not able to perform a service, if you need to clean their teeth or you need to look at a pain that's going on, maybe to have someone divert. And I can't get into all the specifics on that, but diversion is incredibly important. And you can read through the rest. Lecturing, I mean, reassuring versus lecturing. I told you, or remember, or you can't. It's not even going to be processed. And of course, just encouraging and reinforcing, and as well as like working with caregivers on this. With any provider, trustworthiness, trusting is so important. With a geriatric patient, I think the transparency, of course, is so important. And you're really working with their caregiver. Note-taking, I put receipts, but what I really meant dyslexically is reports and evaluations. Really making those available to the caregiver and sharing with the family and talking about some options, and really just being open, I think, is in a critical part. Let me take a look at the time. So looking at patient-centric planning, basically, again, some of the components: family support, resources, accessing those, Medicare, Medicaid, private pay. How do you navigate the system or have resources? Again, working with your community, being a part of it, not only really helps you to understand the needs of your community, but it really adds to you as a provider being there to interact with your community and understanding the needs, the resources, understanding who's available, and having that integrative approach to care that will just enhance the geriatric care experience. I'll let you read through these again. These are different components that we're looking at: clinic, providing access to healthcare, Again, as patients transition, they're newly diagnosed or they already have advanced Alzheimer's or comorbid conditions. Also working with those that are taking many medications that impact them cognitively. It's something I can't really go into at length here. I could probably speak hours on polypharmacy and prescriptive misuse. But these are all factors that go into care. Really looking at the coordination of other PCPs, pharmacists, looking as much as you can glean and gain information on their health status and care, behavioral support, focusing on the training, having options. Sometimes I even ask providers to put up a poster in their break room or in their nursing station that really reminds them about different communication, about your physical approach. Instead of leaning over, maybe sitting so you're more on their level, it's less invasive and can be threatening, really. And really looking at more comprehensive approach. I think we're all providers because we want to help people, and we already have a component of humanitarianism in us. I think it's important to really, with geriatric patients, any patients, understand their attitudes and feelings to some degree as we can, and where they're at. Looking at early intervention strategies to reduce risk of infection, and really, I would like to say 40 is the new 60. We need to begin at age 40, really focusing on enhanced oral health care. So we're reducing the risk of caries, of any infection, and really asking, do you want to keep your teeth, dietary food? So really, you have a great opportunity to say, hey, you're at this age where we really need to have a serious talk and do preventative measures. And again, enhancing your oral health care needs, not only with yourself, but with your staff. Briefly, a little chart looking at with geriatric patients, contacting their family, working with a nursing home, getting as much patient background, medical, prescriptive, behavioral, a comprehensive, again, I can't state that enough, familiarizing with new forms of treatment planning, services, your equipment, the layout of your practice, and again, integrating those services. I think this is a great printout to just have as a reminder always of the path for geriatric care. And again, I won't go into this ad nauseum, but training, safety measures, understanding types of behavioral conditions as Alzheimer's, Parkinson's, comorbid, limitations with mobility, and maybe enhanced reporting, as well as any patients that are living in nursing homes and such. Briefly, it's kind of an overview of where your geriatric patient is today. Bridging the gap, following up with your caregiver, the caregiver of your patient, in terms of discharge or treatment planning, really looking at that caregiver specifically, almost caregiver autonomy as well, and where they're at with their housing or what they're able to do. And there are so many new types of oral health equipment and products for geriatric patients, I think that's worth staying informed on. And family questionnaire follow-up, looking at how you can even enhance your oral care. I'll let you read through this. A more comprehensive approach, especially during this pandemic and what's continuing, unfortunately, is how to keep them safe. Of course, we want to minimize any kind of oral infections and diseases, keeping everyone safe. Outreach, a really great opportunity for oral health care providers to do an outreach and education. And it really enhances your situation in your community. And I'll let you read through those. Again, I'm a broken record. I just keep saying all of these things. Training, they all reduce risk and they just enhance your practices. Integrative approach, it just really shows your community and your patients that this is a trusting environment. We have your back here at this dentist's office, and we're prepared for the geriatric patient. And here's how we've made changes. And here's our training, here's our certifications, coordination with other providers and resources, and walking beside the patient and really knowing, again, that autonomy, what's available. I can't say this enough, and every time I say these words, I get goosebumps because they're so dear to me as a provider. Justice, beneficence, and autonomy. We're really looking at ethical care. And I say, of course, providers provide ethical care. That's a given. With geriatric care, it's a whole different mindset of behavioral issues, et cetera, like we talked about. And they're human rights and changes that we can keep on track of. And again, improving their quality of life. Going to briefly just ensuring your staff, your providers, your patients, their loved ones are all protected. Again, one thing I didn't mention because it could be a whole training on its own are any respiratory illnesses, anyone too that's on dialysis and such, a higher level of increased risk. So as they're needing oral health care, just to keep all that in mind. And of course, I know all of you do preventative measures, vaccines. I won't go into that, but incredibly important for safety. I found these two quotes, and they're very dear to me as a provider. A good physician treats the disease. A great physician treats the patient who has the disease. It really gets to me because geriatric patients as a whole, based on the statistics out there today, are not always treated with autonomy. There's not enough understanding of the geriatric patient and their needs. So to have the training, to have the support, the changes to your practice, you are going to be at the forefront of treating this geriatric community. And best clinical decisions are at the heart of appropriate care, the goal to which our system should aspire. And my hope is that there are some insurance changes that will help with care. And again, I hope today you had just a 30,000 foot level of understanding some geriatric client needs, identifying areas, roles in this process, and learning new approaches. And that is all I have. And I welcome any questions that you might have.
Oh, thank you, Dr. Holzner. What a wonderful presentation, and timed it perfect. This was, we do have some questions, so let's go ahead and get to them. In the Q&A box from Dr. Dar, she says, excellent presentation. Would you please share some recommendations for courses on role play and treatment plan for geriatric population?
You mean resources for training?
I believe so. She was, some role play exercises, or yes, Dr. Darsh, she answered yes to you. Some resources for those role playing exercises.
Well, I would say hopefully that the ADA has training courses. I hope that now these courses are somewhat limited right now. I hope that the Texas Oral Health Coalition, that hopefully we might be able to provide more specific courses on training. I would check with the ADA for your area of training. There are some continuing education course resources out there, and I will send a few of those to Beth and get those out there. And I think they do have some oral healthcare provider trainings. So those are just a few that I have. I will say there's a huge need for this, not only with oral healthcare, but with audiologists and providers. So I'll follow up and give as much information as I can. And Dr. Saunders, the Houston and UNT programs. Okay, wonderful.
Oh, thank you, Dr. Saunders. All right. Oh, and if anyone would like to raise the hand at the little icon, the hand icon at the bottom, we can unmute you if you would like to ask a question verbally. Armando, how can we make dentures more affordable? Do you have a list of resources? Good question.
Oh, yeah.
Pricing.
That is a great question. That's the $1 million question. I think, I don't know if I have the answers to that because I focus more on the behavioral health care. However, I think that from what I understand, in Texas, Medicaid might cover emergent dental services. And then make dentures. I don't have a definitive answer on that. I apologize, but I will do some research on that and provide that for Beth, that she can provide to you. I'm so sorry on that. Yeah, right now, from what I see with Medicare or any dental services, there is such a limitation. It's a huge topic, and one that really needs to come to the forefront legislatively, and to get access for funding. So my apologies on not knowing.
No, and that's okay, because the cost of dentures, it varies from place to place all over Texas. So it depends on which facility that you're in and things like that. But we can help. We'll work with you, Armando, and see if we can't find a list of resources for your area that you could use.
I know in Oregon, we have a couple organizations that are sort of they're funded and they're basically traveling dentists that will go out to rural communities and such, and they provide dental care at no cost, limited, sliding scale or no cost. And so I can check also and maybe work with Beth on if there are any in the Texas area that that might help support that. But for oral health providers themselves, yeah, there needs to be some changes so that they can enhance their own practices.
You are so right. Okay, so we'll work on that and see what we can get for you. So with that, I do believe it's time. If you have any follow-up questions or anything, please feel free to email me at info@texsoc.org. And Dr. Holzner, we want to thank you again so much for your time and this informative presentation. We really appreciate it. And have a good afternoon, everyone. We appreciate you attending today.
Thank you so much.
Thank you. Bye-bye, and have a good weekend.